Episode 24 Proximal Control Vascular Surgery Exam Prep. Vascular Trauma. Abdominal vascular trauma, damage control surgery, and blunt traumatic aortic injury, which is BTI. FRCS and European Board Vascular Surgery Exam Focused Teaching. Welcome back to Proximal Control. I'm your host, Bomia. This is the podcast where we prepare for the vascular exams the same way we practice as a day one consultant, with structure, judgment, and control. Because in vascular surgery, control is everything. Alright, welcome back to Proximal Control. This is a high-yield revision episode on vascular trauma, and we will discuss about abdominal vascular trauma, damage control surgery, and blunt traumatic aortic injury. So let's begin with abdominal vascular trauma. In civilian practice, abdominal vascular injuries accompany around 5 to 25% of all abdominal injuries. Now, the mechanism split is important. Penetrating trauma accounts for approximately 90% of all traumatic abdominal vascular injuries. Break that down further. Gunshot wounds represent around 15 to 25% of all major vessel injuries, and stab injuries cause vessel injuries in 10% of patients undergoing laparotomy. In blunt trauma, road traffic accidents or falls, the incidence of major vessel injury is much lower at just 3 to 5%. Among large vessel injuries in the abdomen, the IVC is the most commonly injured at 25%, followed by the abdominal aorta at 21%, then iliac arteries at 20%, iliac veins at 17%, and the superior mesenteric vessels, vein and artery at 11% and 10% respectively. Venous and arterial injuries occur equally frequently overall. The geographical point is worth knowing too. In most European countries, blunt trauma from road traffic accidents predominates, whilst penetrating trauma is mainly confined to stab wounds. In North America and South Africa, firearms-related deaths are the leading cause of trauma death. This matters for understanding the case mix. Now let's talk about the mechanisms that you need to know. Any penetrating injury can cause vessel transection, laceration, restricted damage to the intima, and secondary events such as thrombosis, pseudoaneurysms, and arteriovenous fistula. Stab wounds to the abdomen penetrate the peritoneum in approximately 50% of all cases. So you cannot assume a stab wound is superficial simply because the patient looks well on arrival. For firearms, the energy transfer depends on missile velocity. Handguns with low velocity causes less damage than high velocity weapons, which can cause thrombosis of surrounding arteries and veins within 10 to 15 centimeters of the trajectory. That's an important radius to remember. It's why seemingly distant vessels can be injured. For blunt trauma, the mechanisms are crush injuries, shearing forces, bursting of hollow organ, and penetration by bone fragments. The classic examples, the seat belt injury in motor vehicle accidents. This may involve lumbar spine injuries and associated aortic trauma. Blunt abdominal aortic injury include intimal tears with thrombosis or rupture, and retroperitoneal bleeding. Here's a high-yield sequence for deceleration trauma that comes up sometimes in the viva. Major abdominal trauma causes avulsion of vessels in the following descending order: the left renal vein, renal artery, superior mesenteric artery, and abdominal aorta distal to the renal arteries. Venous damage from deceleration, except damage to the left renal vein, is uncommon. One key physiological point here is complete arterial transection is generally better than a partial laceration, because vessel spasm can lead to spontaneous interruption of ongoing extravasation. This seems counterintuitive, but this is frequently the fact. Now let's talk about the clinical presentation. The history and examination in viva will pointing you towards the diagnosis. So know the signs. If there is a hypovolemic shock after abdominal trauma, suspect major vascular injury with ongoing bleeding. Abdominal distension plus persistent hypotension despite fluid resuscitation is meaning bleeding from vascular injury or liver or spleen. Two highly specific findings that you need to know. First, no palpable femoral pulse in a patient with abdominal penetrating trauma or pelvic fracture means iliac artery injury until proven otherwise. Second, absence of bilateral femoral pulses after blunt trauma means aortic thrombosis until proven otherwise. After blunt trauma, specifically distal ischemia may be the only sign of abdominal vascular injury. This is the silent presentation. Retroperitoneal tamponade has contained the hematoma. The patient is hemodynamically stable. The only clue is a cold, pale leg. The clinical rule: all penetrating wounds between the transnipple line and the groin may cause intra-abdominal injury. And for every major abdominal vessel injury, roughly 3 or 4 other organs are injured. Always think multi-organ injury. Now let's talk about the surgical anatomy, the zone classification. This is the anatomical framework that structures everything else. The retroperitoneal hematomas and bleeding sites are divided into 4 anatomical zones. Zone 1, midline retroperitoneum. This is the most important zone. It contains the abdominal aorta, IVC, their proximal branches, and tributaries. Zone 1 is divided into supramesocolic zone and inframesocolic zone. Supramesocolic zone 1 is the suprarenal aorta and IVC, celiac axis, proximal SMA, and vein, proximal renal arteries and veins. Inframesocolic zone 1 is the infrarenal aorta and IVC, including their bifurcations. Now let's talk about zone 2. Zone 2 is the lateral retroperitoneum that contains the distal renal arteries and veins. And zone 3 is the pelvic retroperitoneum that contains the iliac arteries and veins. And zone 4, that is the final zone, is the portal and retrohepatic area. This contains the portal vein, hepatic artery, retrohepatic IVC, and hepatic veins. Now let's talk about the management rules by zone. Zone 1, midline hematomas should always be explored, both penetrating and blunt. So zone 1 for retroperitoneal hematoma, always explore, irrespective of the mechanism of injury. The major vessels in this area demand it. If the bleeding appears arterial, left medial visceral rotation. If it's venous, right medial visceral rotation. So we already know left medial rotation to explore the aorta, right medial rotation to explore the IVC. Now let's talk about the zone 2. Lateral hematomas after blunt trauma are usually treated non-operatively unless the hematoma is pulsating or expanding. After penetrating injury, a more selective approach can be adopted if damage to the bowel or renal vessels can be excluded. Now let's talk about the zone 3, that is the pelvic hematomas. Now let's talk about zone 3, pelvic hematomas. If the pelvic hematomas are due to penetrating injury that need exploration, after obtaining the proximal and distal vascular control, blunt pelvic hematomas are usually managed by a combination of fracture stabilization, angiography with embolization of arterial extravasation, and in certain cases, preperitoneal packing. So, zone 3, if it is penetrating, needs exploration. If it is blunt, you may manage with combination of fracture stabilization, embolization, and in certain cases, packing. Now let's talk about zone 4, which is the portal area. Portal area hematomas should be explored after both penetrating and blunt trauma. However, a retrohepatic hematoma, if not actively bleeding, should not be explored irrespective of the trauma mechanism. This is a critical distinction. Retrohepatic IVC injuries are among the most lethal in surgery. Premature exploration of a contained hematoma is dangerous in this context. Okay, so let's do a bit of sum up. Zone 1, if it is supramesocolic, whether it's penetrating or blunt, you explore. And for the supramesocolic, the left medial visceral rotation, aorta below the diaphragm. Zone 1 inframesocolic, it's again explore for both penetrating or blunt, and again, if it is, we already discussed, if it is venous bleeding, you do right medial visceral rotation, and also to have a look at the infrarenal aorta or IVC. Zone 2, it's lateral. We already said if it is penetrating and you selectively explore. If it is blunt, you do not, most of the time you need to explore. And how you do it, if you have to do exploration, you can do visceral rotation to reach the infrarenal aorta or renal hilum. Zone 3 pelvic hematomas, we already said, if it is penetrating, you explore. If it is blunt, you do fracture stabilization, sometimes embolization of the bleeding vessel. And if you have to explore, you can do visceral rotation, you do distal and proximal control, of course. Zone 4 is the portal hematomas, we already said. If it is portal hematoma and if it's penetrating, you have to explore it, or even it's blunt, you explore. So you explore in both cases. And how you do it: hepatoduodenal ligament and then cauterization. You apply the Pringle maneuver to control the bleeding. If it is retrohepatic in zone 4, then you do not explore. And if you have to explore, then divide the hepatic ligaments, and you may need to do sternotomy, and you have to have supra and infra hepatic IVC control. You may need Pringle's maneuver as well. So zone 4, you need to know, unless you have to try managing conservatively, because it's the most lethal to disturb the hematoma in zone 4 retrohepatic position. Let's talk about some diagnostics now. In the hemodynamically unstable patient, straight to the operating room for emergency laparotomy. No prior diagnostics. For the stable patient, the tools are FAST, that is focused assessment with sonography in trauma. This detects hemoperitoneum as a source of hypotension. It can be performed in the emergency department without moving the patient. A positive FAST in an unstable patient means laparotomy. A negative FAST does not rule out intra-abdominal bleeding. Crucially, retroperitoneal bleeding is often not identified by FAST. What about the CT? CT is the most important diagnostic modality for stable patients. This provides detailed retroperitoneal assessment, hemoperitoneum, active bleeding, pseudoaneurysms, and organ injuries. Its main limitation is the inability to detect early bowel perforation or minor diaphragmatic injuries. CT can identify patients who do not need laparotomy and those who may undergo angiography for embolization. What about diagnostic angiography? This is rarely used today for diagnosis alone, but has a role in hemodynamically stable patients where CT is inconclusive and therapeutic intervention is planned. The classic indications could be hepatic arteriovenous fistula and pseudoaneurysms, splenic injuries, or active extravasation from arterial branches after pelvic fracture. What about diagnostic peritoneal lavage? DPL, largely replaced by CT, may be indicated when bleeding location is unknown, FAST is inconclusive, and CT is unavailable. Remember, retroperitoneal bleeding is usually not diagnosed with DPL because we are looking at the peritoneal cavity, so you cannot get the retroperitoneal diagnosis here. Laparoscopy is not indicated to evaluate suspected vascular injuries. Its greatest advantage is diagnosing diaphragmatic injuries in stable patients. Let's talk about the resuscitation. Permissive hypotension with a systolic blood pressure of 70 to 90 mm is a reasonable target in both penetrating and blunt abdominal trauma until definitive hemorrhage control is achieved. The current strategy include restrictive crystalloid use with early blood component therapy. Damage control resuscitation is another important point, targeting the lethal triad of coagulopathy, acidosis, and hypothermia. For unconscious patients with penetrating trauma, severe hypotension below 70 mm mercury, and a distended abdomen, emergency thoracotomy to control the aorta may be the first appropriate step. The descending thoracic aorta is rapidly exposed via a left anterolateral thoracotomy in the fourth or fifth intercostal space. Damage control strategy should be considered when injury is extensive and combined with any of indication for thoracotomy, multi-organ dysfunction, open pelvic injury, traumatic amputation, initial pH less or equals 7.2, temperature less or equals 34 degree, and or initial IV fluid resuscitation during transport is more or equals 2000 ml or 2 units of blood transfusion. So these are the important topics to remember when to consider damage control surgery. The most important thing is to remember that when the injury is extensive and combined, then you think about damage control. Now let's talk about the temporary hemorrhage control. REBOA, the resuscitative endovascular balloon occlusion of the aorta. This can be used as an adjunct in hemodynamically unstable patients. Percutaneous access via the common femoral artery, stiff guide wire advanced to the descending thoracic aorta. A 12 French compliant balloon is deployed in aortic zone 1, the distal descending thoracic aorta, from the origin of the left subclavian artery to the celiac artery. So just not to make it confused, this is the REBOA zone for the aorta. This is not the retroperitoneal zone, and this is not the Ishimaro zones. This is only aortic zones for the REBOA use. Okay, so you deploy in abdominal aortic injury. To control the bleeding, you need to go above, right? That is the zone 1, that's the REBOA aortic zone 1, between the left subclavian and diaphragm, that's the descending thoracic aorta. So if you control the descending thoracic aorta, you are literally controlling the abdominal bleeding inflow, right? Okay, good. So let's carry on now. The balloon temporarily slows the bleeding and optimizes central perfusion. If rapidly available, it has potential advantages over emergency thoracotomy. If we are already intra-abdominal and there is large volume of bleeding, digital or manual pressure first. If the bleeding point is obvious, a clamp is placed. Blind application of clamp is discouraged, as they may cause damage to fragile iliac veins and the IVC or any other fragile adjacent organs. Local hemostatic agents with intravascular balloons, that is Foley catheter or Fogarty balloons, can be used locally. Now let's talk about the vascular damage control. There are 3 techniques very important to know. First, the shunting. A temporary vascular shunt quickly restores the distal perfusion. Specialized vascular shunts such as Javid shunt may be used, but a sterile, suitable size plastic tube such as nasogastric tube or chest tube even works well. Shunts can remain patent for up to 24 hours without systemic heparin. This is very important to know. Ligation. In a damage control situation, quick and potential life-saving procedure is ligation. Temporary shunting should always be considered first before you plan ligation of the arteries. All complex venous injuries in the critical situation could be ligated. So the ligation rules, very important to know. Arteries that require mandatory shunting or repair, that means you cannot ligate, are the proximal SMA and suprarenal aorta. These you cannot ligate. You can understand that anyway. Ligation of common or external iliac arteries, there is a risk of 50% amputation. So do not ligate if you can. Ligation of the celiac axis or inferior mesenteric artery or internal iliac artery can usually be done safely without significant ischemia. If the renal artery is severely damaged, nephrectomy is the best option if the other kidney is intact. If the common hepatic or right hepatic artery is ligated, cholecystectomy must be performed to prevent acute gangrenous cholecystitis. So if you have to ligate the common hepatic, that means you are already sacrificing the cystic artery supplying the gallbladder. That will be gangrenous anyway, you know that. So to do cholecystectomy as a prophylactic measures at the same time is recommended. Now what about the portal vein and the superior mesenteric vein ligation? Is it valid? Yes, it is. In extremes, but this can cause massive midgut edema requiring aggressive resuscitation with risk of bowel ischemia. So this is only recommended in extreme situation. That is the portal vein and superior mesenteric vein ligation. You can consider, but only in extreme situation. What about the IVC or common or external iliac vein ligation? This causes transient limb edema, but rarely limb ischemia or amputation is required. So if it is torrential bleeding and you cannot control, you can ligate IVC or common or external iliac veins without risking the limbs in most of the cases. Now, if we talk about some endovascular techniques in hybrid suites, and there is a concept that you need to be familiar with, that is the Raptor concept, that is resuscitation with angiography, percutaneous techniques, and operative repair. This is called as Raptor concept. That is resuscitation with angiography, percutaneous techniques, and operative repair, altogether called Raptor. Okay, these have changed the game. The balloon occlusion of the aorta and arterial embolization are part of the damage control procedure. Stent grafts can act as bridge for temporary vessel repair. Angioembolization is well established for internal iliac artery branches, spleen, liver, and kidneys. So this can be performed only in hybrid suites. Remember that, okay? So the Raptor basically means is resuscitation with angiography, that is the balloon occlusion of the aorta, and then you do the percutaneous techniques, that is the embolization of the bleeding vessels as a part of the damage control procedure, and you can also put a stent grafts as appropriate. Now let's talk about the specific vessels injuries. Let's start with the abdominal aorta. Blunt abdominal aortic injury is rare. Only 5% of all traumatic aortic injuries. The most common injured site after blunt trauma is the infrarenal aorta, at the level of the inferior mesenteric artery and below. If you have to expose this area, you need to do left medial visceral rotation. This combined with intra-aortic occlusion balloon at the level of the diaphragm or left anterolateral thoracotomy with cross-clamping of the descending thoracic aorta. The management of simple laceration is lateral aortography with pledgeted suture. If it's complex injuries, you can do interposition Dacron or PTFE graft. For blunt injuries with peritoneal contamination from bowel injuries, endovascular stent graft is a particular attractive option. Non-operative management with blood pressure control, antiplatelet therapy, and closed follow-up is successful for intimal tears and minimal thrombus only. Now let's talk about the inferior vena cava. The IVC is the most commonly injured abdominal vessel. In-hospital mortality is 20 to 57%. There are 4 parts, as we already know: infrarenal, suprarenal, retrohepatic, and intrapericardial. The penetrating trauma can injure any portion. Blunt trauma most commonly affects the retrohepatic and intrapericardial portions. 3 most important prognostic factors: hemodynamic status on arrival, presence of contained hematoma, and location of the injury. If you have to expose infrahepatic IVC, you need to do right medial visceral rotation and cauterization. If you have to expose the retrohepatic and suprahepatic IVC, you need to consider right subcostal incision combined with either right thoracotomy or sternotomy. And what about the control? Digital pressure, sponge sticks, flat blade of Langenbach, retractors, Babcock clamps on wound edges, or intraluminal balloon catheters. These all can be used as a control. Partial vascular occlusion clamp carefully can also be applied. What about the management of IVC injury? If possible, we can repair laterally with 3-0 or 4-0 monofilament suture that could be Prolene. For infrarenal IVC failure to lateral repair, you can consider ligation. For suprarenal IVC, vein patch or ringed PTFE graft can be considered, but ligation may be necessary to save life even at risk of renal failure. So what about the retrohepatic IVC? Pack first, do not explore. If packing fails, repack and optimize coagulopathy. But if you have to explore, the techniques that described include hepatic vascular isolation. This is a combination of cross-clamping of the infradiaphragmatic aorta plus supra and infrahepatic IVC plus Pringle maneuver. And you can also think of atriocaval shunting, but the prognosis is extremely poor for all this. What about infrarenal IVC ligation? This can usually well tolerated. Lower extremity edema requires leg elevation, compression stockings, intermittent pneumatic compression. A minority may develop compartment syndrome requiring fasciotomy. Now let's talk about the iliac vessels injury. mostly from penetrating trauma. Common iliac vessels most frequently involved. There could be common iliac arteries or veins. Blunt trauma causes intimal damage from shearing forces, that is, pelvic fractures. Ligation rules already stated before in damage control. Temporary intravascular shunt has largely replaced the need for ligation of the common and external iliac arteries. Endovascularly occlusion balloon or stent graft. These are very valuable options. If the right common iliac artery must be divided to access the underlying iliac vein, it should be avoided if possible, but can be done. Now let's talk about the superior mesenteric artery. Blunt trauma accounts for 10 to 20% of all SMA injuries. Delay in restoring SMA blood flow, the intestinal ischemia, necrosis, and this leads to fatal outcome. There is a full-end classification which divides the SMA into 4 zones. Zone 1, Zone 2, these are the SMA trunk to the middle colic artery, and this requires repair to prevent small bowel and right colon ischemia. More distal injuries can be ligated. This may result in small bowel ischemia requiring segmental resection. In a critical situation, temporary shunt in the SMA can be placed. Primary repair with lateral arteriography if possible, vein patch if needed to prevent luminal narrowing in a small vasoconstricted artery. If primary repair not possible, interposition graft or bypass with saphenous vein or PTFE from the infrarenal aorta to the SMA placed away from the pancreas if pancreatic injury is suspected. Celiac axis and inferior mesenteric artery injuries can usually be ligated. What about the portal vein? Mostly penetrating trauma injures the portal vein and highly associated with mortality. Exposure is with the right medial visceral rotation with extensive cochlear mobilization. If further access needed, stable division of the neck of the pancreas to expose the retropancreatic portal vein. The managements are lateral venography if possible. Shunting is feasible. Ligation is an option, but ligation of both the portal vein and the hepatic artery is not survivable. The portal vein must be reconstructed in that scenario. Now let's talk about another important topic, that is renovascular injuries. Most common renal artery injury after blunt trauma is thrombosis. The mechanism is acceleration or deceleration causing intimal disruption and thrombosis. The time window, if diagnosis is made within 6 hours, then you revascularize. After 12 hours, viability of the kidney is limited, but successful revascularization has been described even after 24 hours. In bilateral renal artery injury or injury to a solitary kidney, a more liberal approach to reconstruction should be adopted. However, only 25% of the cases managed by open repair result in preservation of renal function. This is why non-operative treatment and long-term monitoring for hypertension is recommended in most cases, with revascularization reserved for intraoperative discoveries in stable patients or bilateral solitary kidney injuries. So, because only 25% cases managed by open repair result in preservation of renal function, that's why most of the time it's managed with conservative approach. But of course, if it's a solitary kidney, you need to consider them saving it, or even if it's a bilateral renal artery injury, then you can't risk both kidneys to lose. Okay, what about the renal vein? You consider repairing it first with lateral venography. If ligation is necessary, left renal vein can be ligated closer to the IVC safely due to the collateral outflow from the adrenal, gonadal, and lumbar veins. So if you have to tie the left renal, tie closer to IVC. Ligation of the right renal vein means nephrectomy because there are no venous collaterals. Now let's talk about the postoperative care and complications. Okay, now let's talk about postoperative care and complications. After abdominal vascular trauma, expect complications. In a series of 302 patients, almost 128 major complications were reported. The most frequent were multisystem organ failure and sepsis. Main cause of early operation were hemorrhage, intra-abdominal hypertension, and abdominal compartment syndrome. The late complications included infection of prosthetic grafts, aortoenteric fistula. Important and highly tested are pseudoaneurysm, arteriovenous fistula, also chronic renal failure and renovascular hypertensions were there. Damage control second look laparotomy. This is typically done at 24 to 48 hours. Signs of continuing bleeding despite correction of coagulopathy and metabolic derangements are the reason for urgent laparotomy. At second look, shunted vessels are reconstructed, suture lines covered with retroperitoneum or omentum, copious washout if contamination present. Now let's briefly talk about abdominal compartment syndrome, which we have already discussed in detail in the abdominal aortic aneurysm episode. Okay. High risk after abdominal vascular injury combined with visceral injuries, particularly if the abdomen is closed after damage control surgery. Primary fascial closure should be avoided in most cases. The methods of temporary abdominal closure you need to know. That could be sandwich technique or commercially available negative pressure dressings. Intra-abdominal pressure monitoring by a pressure transducer connected to a Foley bladder catheter can be done. Threshold for intervention if intra-abdominal pressure more or equals to 20 mm mercury and there is hypoperfusion evident by organ malfunction, then you consider urgent abdominal decompression. What about the outcome of this? Mortality from isolated penetrating abdominal vascular trauma is around 25 to 60%. The classic data from a study showed 300 consecutive laparotomies for gunshot wounds. The survival rate dropped from 97% to 61% if vascular injury was present. Patients with isolated visceral injuries, and if they are unstable, mortality was 60 to 70% as reported. However, if they were hemodynamically stable on admission, much more favorable outcomes were reported. The blood pressure threshold, the mortality 61% patients with initial systolic blood pressure below 60 mm mercury versus only 19% mortality in patients with systolic blood pressure above 60 mm mercury on presentation. That systolic blood pressure threshold is an important number to remember. Multiple vessel injuries increase mortality substantially. When both the IVC and the abdominal aorta are damaged, the prognosis is extremely poor. Now let's summarize the abdominal vascular injury. This consists of 5 to 25% of abdominal trauma, 90% are penetrating. IVC is the most commonly involved in around 25%, then aorta 21%, iliac 20%, and in blunt trauma, it's only 3 to 5% cases the blood vessels are injured. The vessels in blunt trauma injury from higher to lower number is left renal vein, then renal artery, then SMA, and then infrarenal aorta. So you can see the left renal vein is the mostly involved vessel. Now let's talk about the zones in summary. Zone 1 is the midline, always explore. Zone 2 is the lateral. Blunt trauma, observe unless expanding or pulsating. Zone 3, pelvic. Penetrating, then explore. Blunt, then you can manage with embolization. Zone 4, portal, then explore in both blunt and penetrating. However, if it's retrohepatic, do not explore if not bleeding actively. Let's talk about the REBOA. Zone 1 aortic balloon. You apply in the left subclavian to celiac, and the 12 French balloon via the femoral artery. Let's talk about the REBOA. For zone 1 aortic injury, you can apply the REBOA in the REBOA zone 1, that is the left subclavian and celiac in between in the descending thoracic aorta, and that should be 12 French balloon via femoral artery. Key ligation rules are, as we said, SMA trunk plus suprarenal aorta must be repaired because it cannot be ligated with a survival situation. Common or external iliac can be ligated with 50% amputation risk. Celiac, IMA, and internal iliac can be ligated without major consequences. Right hepatic ligation should follow with cholecystectomy. Right renal vein ligation should mostly need nephrectomy. Left renal vein safely ligated closer to the IVC. IVC, if retrohepatic injury, PAC, do not explore unless bleeding uncontrollably. SMA, full end zones 1 to 2 must repair. Zone 3 to 4 can be ligated as they are more distal. Abdominal compartment syndrome, we already said, pressure more or equals to 20 with organ hypoperfusion, decompressive laparotomy. No primary fascial closure after damage control should be done. Negative pressure dressing or sandwich technique needs to be followed. Mortality with systolic blood pressure less than 60 mm mercury on arrival is 60%. Mortality with systolic blood pressure more than 60 mm mercury is 19%. So almost 1/3. Okay, now we are going to talk about a very important topic, that is damage control surgery for vascular trauma. This is very high yield, so we will try to cover most important bits of it. Let's start with the pathophysiology. In major vascular trauma, 3 life-threatening processes activate simultaneously: hemorrhage and exsanguination, regional end organ ischemia, and systemic inflammatory response, that is SIRS. Hemorrhagic shock follows loss of at least 30% of blood volume. In blunt trauma, hypovolemia causes shock in over 59% of cases. Massive hemorrhage is defined as loss of one of full blood volume within 24 hours or half a blood volume within 3 hours. Now, the concept you must know is the lethal triad, that is coagulopathy, hypothermia, and acidosis. Coagulopathy is present in up to 1/3 of bleeding trauma patients on arrival, and in virtually all with massive hemorrhage. Hypothermia impairs platelet function and reduces coagulation factor activity, critically below 33 degrees centigrade, and induces fibrinolysis. Acidosis at pH below 7.4 impairs platelet shape and function, thrombin generation, and accelerates fibrinogen degradation. These 3 are mutually reinforcing. The core principle here is, in major trauma, there is a significant risk of irreversible secondary injury in physiologically depleted host from prolonged resuscitation and surgery. Damage control exists to break this cycle before it becomes fatal. Now let's talk about some clinical assessment. You need to know about the hard signs and soft signs. The hard signs mandate immediate action. These include pulsatile bleeding, expanding hematoma, absent distal pulses, cold and pale limb, palpable thrill, audible bruit. And the soft signs that require investigation, these are small hematoma, history of hemorrhage at scene, unexplained hypotension or tachycardia, and peripheral nerve deficit. You have to know about the scoring, triages, and damage control surgery triggers. So you need to know some of the scoring systems, such as physiological scoring. These include revised trauma scoring, and there are some other ones such as Apache, SARS score, emergency trauma score. DCS, that is damage control surgery, should be triggered by hemorrhage exceeding 40% of blood volume, pH below 7.2, or base deficit at or beyond -8 milliequivalent per liter, or diffuse coagulopathy. So when you initiate the damage control surgery approach, these are the 4 things that you need to remember by heart. Hemorrhage exceeding 40% of the blood volume, pH below 7.2, or base deficit at or beyond -8 milliequivalent per liter, or diffuse coagulopathy. So if a patient has 2 liters of blood loss or more than 2 liters of blood loss, that would require a damage control surgery, right? Okay. Now, what about the metabolic markers? Serial hematocrit beats a single reading after fluid resuscitation. Lactate is an indirect marker of oxygen depth. We target normalization to 2 millimole per liter or below. A base deficit below -6 combined with acidemia and raised lactate increase the odds of death by 4-fold. Assess coagulopathy with INR, APTT, fibrinogen, platelets, and where expertise exists, thromboelastogram or TEG. Now, what about the imaging? We already said imaging stratify by the stability. Unstable patients go straight to theater. Imaging delays are dangerous. Stable patients get diagnostic imaging first. Handheld Doppler and ABPI in extremity trauma. A normal ABPI confidently excludes major arterial limb injury. FAST, that is the focus abdominal sonography for trauma, which we already says approaches nearly 100% sensitivity and specificity in hypotensive patients, as demonstrated by Rosicki et al. For stable patients with suspected torso injury or high-risk mechanism, multi-slice CT angio is recommended. Whole body CT in polytrauma is now standard practice. DSA is reserved for intraprocedural use during endovascular intervention only. Now let's talk about another important topic of damage control surgery is damage control resuscitation. Volume resuscitation improves oxygen delivery, but excessive fluid before hemorrhage control encourages clot dislodgement and rebleeding. The cornerstone of permissive hypotension is permissive hypotension. Maintain a MAP around 50 to 60 millimeter mercury, roughly 70 to 80% of normal. So remember the number, MAP target should be around 50 to 60 millimeter, roughly 70 to 80% of the normal MAP. Do not chase a normal blood pressure in uncontrolled hemorrhage. For massive transfusion, replace whole blood that is lost and with balanced blood products. The Borgman military data is a landmark. Mortality was 65% with less than 1 unit FFP per 4 units RVC. The mortality dropped to 20% with a ratio of 1:2 or above. Cotton et al. Showed a trauma exsanguination protocol reduced the odds ratio of mortality by 74%. Another important adjunct is tranexamic acid, and this addresses post-injury fibrinolysis. If you think about the CRASH 2 trial, which included 20,000 patients, that demonstrated a mortality benefit when tranexamic acid was given within the first 3 hours. Late administration is not beneficial. Give it early or not at all. Now let's talk about the recombinant factor 7A. At 1 milligram provides 5 to 10 times the normal circulating concentration. Prothrombin complex concentrate offers rapid reversal of established coagulopathy, faster than liquid plasma alone. So, if there's established coagulopathy, consider prothrombin complex concentrate. Now let's talk about the operative management in damage control situation. For external hemorrhage, direct pressure bandage, hemostatic dressings, or tourniquet can be applied. Military evidence supports tourniquet use, but prolonged application beyond 2 hours risks ischemia and pressure nerve injury. Rapid triage prevents this. Temporary intraluminal vascular shunts are the elegant damage control tool. They simultaneously control bleeding and restore oxygenated flow to the distal limbs, and buy time for a structured, multidisciplinary approach. Commercial shunts work well. Sterile, heparinized, polyethylene tubing or chest drains are sufficient for most vessel sizes. Once flow is restored and the shunt is secured, definitive repair can be safely deferred from 24 to 48 hours, allowing correction of the lethal triad. Now let's talk about the principles of vascular repair in damage control situation. Start with the position. Position fully transparent draping of distal extremities for perfusion assessment, donor limbs prepared for vein harvest, table compatible with intraoperative angiography, which most of the time should warrant a hybrid theater. Repair classification in 3 tiers: simple injuries, lateral suture, ligation, patch angioplasty. If it is complex injury, interposition graft with vein or synthetic conduit, end-to-end anastomosis, extra-anatomic bypass can be considered. Super complex with major tissue loss, then you can consider extra-anatomic bypass. The rule is a rapid, simple repair beats a lengthy, complex repair in an unstable polytrauma patient. There are some specific decisions. If the laceration is under 50% circumferential, then lateral suture can be applied. Over 50% of the lumen or in juvenile patients with small elastic vessels, lateral repair will narrow the vessel. Use patch angioplasty or interposition grafting. Complete transection needed interposition grafting. Injury always extends beyond the visible laceration. Mobilization rarely achieves tension-free primary repair. So consider interposition grafting to avoid tension in your repair site. Clear inflow and outflow with proximal and distal balloon embolectomy catheter passage, then flush with heparinized saline is very important. What about the conduit? Long saphenous vein is the first choice distally. Dacron or PTFE for large proximal vessels. These perform poorly in distal positions. In grossly contaminated wounds with intestinal spillage, anastomosis risks catastrophic septic situation and failure. So, like it and think of extra-anatomic bypass. Spiral or paneled composite vein grafts are reserved for stable patients with single territory injury only. Unstable patient or multi-trauma patient should not go under complex repair. What about the surgical approaches? In upper limb, anteromedial incision extend to clamshell thoracotomy if needed. Lower limb medial approach supplemented with extraperitoneal iliac access or full midline laparotomy if needed. In the abdomen, you can consider about midline laparotomy, lateral or medial visceral rotation depending on the site of the injury. Thorax, the commonest source of bleeding in chest trauma is intercostal artery injury. So think about that as well. There are some key numbers to remember in damage control situation. 50% trauma deaths within 24 hours, 48% are preventable. Iatrogenic, 50 to 75%. Coagulation critical below 33 degree. DCS triggers if more than 40% blood volume is lost, pH less than 7.2. Base deficit more or equals 8. Or base deficit less than -6 plus acidemia plus high lactate. And this equals mortality 4 times higher than normal. If the laceration target the lactate less or equals 2 millimole and MAP should be 50 to 60 millimeter mercury, FFP to RBC ratio should be more or equals 1:2, and this leads to 20% mortality versus 65% if not followed. Consider tranexamic acid within 3 hours as per the CRASH-2 trials. Shunts always consider, and this can differ repair 24 to 48 hours. Tourniquet should not be used more than 2 hours, otherwise it will cause nerve injury. Less than 50% laceration can laterally be sutured. More or equals to 50% laceration will require patch or interposition. Transection will require interposition graft. Contaminated field, ligate and do extra anatomic bypass. So this was a very important topic about damage control surgery, and this is a high yield revision topic for the exams. Okay, now we are going to discuss about another very important topic, and that is blunt traumatic aortic injury. Let us shift to blunt traumatic aortic injury, and if anything, this is even higher important and very much exam relevant. BTI is the second most common cause of death following blunt trauma, second only to head injury. Always keep this in mind. There is a landmark paper from Palmley 1958 autopsy series reported an 85% pre-hospital mortality. 80 to 90% of patients die before reaching to the hospital. Of those who survive to admission, 50% dies within the first day if untreated. These numbers explain why missed or delayed diagnosis is fatal. The typical BTI patient is in their late 30s to early 40s. 2/3 are male. These are young people with narrow aortas and angulated arches. and that creates specific endovascular challenges we will come to. Key epidemiological figures: 60% of all RTA deaths are caused by BTI, 72% of BTI deaths related to motor vehicle collision. Side impact RTAs are particularly prone to generating BTI. 90% of aortic transections involve other organ damage. 30% have severe extrathoracic trauma. 1/4 arrive with GCS of 8 or below, which directly complicates management. Now let's talk about some anatomy and mechanisms. The aortic isthmus sits between the origin of the left subclavian artery and the ligamentum arteriosum. The ligamentum tethers the aorta at this point. The arch above is mobile. The descending aorta below is mobile, but the isthmus is fixed. In rapid deceleration, shearing the forces concentrate at this transition, producing intimal damage and wall disruption. Let's talk about the injury distribution. Isthmus and left subclavian vicinity are injured in 70 to 90% cases, and the reason we've just explained. Ascending aorta is also sometimes involved in 10 to 15%. Descending thoracic aorta in 5 to 10%. So you can say 70 to 90% at the isthmus level. Now the zone of injury determines landing zone available for endovascular repair. If we think about the mechanisms again, there are 3 mechanisms. Deceleration is very important to remember. This is because of the high velocity, torsion, and stretching. The other mechanism is compression. There are 3 subtypes: osseous pinch between sternum and vertebrae, water hammer effect from sudden intraluminal pressure spike, and direct trauma from fractured vertebrae. The third mechanism is the blast. The cause frequency from some registry data: motor vehicle accident was 68%, motorcycle 13%, falls 7%, pedestrian 6%, and other 6%. So you can see the motor vehicle collision is 68%. It's a big number. And if you combine the 13% from the motorcycles, that makes it almost 80% of the total cause. And that same registry data showed intimal tears were in 21% patients, dissection was 25%, and aneurysms, mostly pseudoaneurysms, were in 59%. The classifications: there are 2 systems. One is the grading system, which has been introduced by Azizadeh et al. That include grade 1, which is intimal tear, grade 2, intramural hematoma, grade 3 is the pseudoaneurysm, and grade 4 is the free rupture. There is another radiological classification, and that was introduced by Starnes et al. Based on external aortic contour abnormality, or ACAB. that is aortic contour abnormality. No ACAB, that means defect or thrombus under 10 mm. This mostly are intimal tear. Again, no ACAB, that is no external aortic contour abnormality, but the defect or thrombus is 10 mm or above. This is especially in large intimal flap. There is the next is ACAB present, that is the contained pseudoaneurysm, and the finally ACAB present with contrast extravasation, that means rupture. Absence of ACAB means low beta associated mortality, and a contained hematoma is an indicator for urgent repair because this has a high rupture risk, and free rupture carries very poor prognosis. So just remember, there are two systems. One is the grading system by Azizadeh et al., and that's the grade 1, grade 2, grade 3, grade 4. The grade 1 is the intimal tear, grade 2 is the intramural hematoma, grade 3 is the pseudoaneurysm, and grade 4 is the free rupture. So there's another one is a radiological classification, that was introduced by Stanes et al., and that is mainly depending on external aortic contour abnormality, that is ACAB. So no ACAB with defect under 10 mm. This is usually in intimal injury. No ACAB with defect more than 10 mm defect or thrombus. This is again in large intimal flap. Next is the ACAB present but contained, that is pseudoaneurysm. And finally ACAB present with contrast extravasation, that is rupture. Absence of ACAB is a good prognostic factor. Now let's talk about the clinical features and investigation. Here is the important thing to know. In most cases, beta is asymptomatic. In polytrauma with destructing injuries, it is devastating and easy to miss. When symptoms occur, chest or back pain, hemoptysis, ecchymosis, rib or vertebral fractures, mediastinal mass effect can produce tracheal deviation, dyspnea or stridor, SVC compression or asphyxia. Hoarse voice suggests laryngeal nerve compression, ruptured aortas present with shock, loss of consciousness, and hemothorax. The classic Palmley important point is 36% of patients with aortic rupture had no significant chest wall injuries. External signs cannot be trusted. Chest X-ray for beta is 7 to 44%, have no mediastinal abnormality. A normal chest X-ray does not exclude the diagnosis. This must be stated confidently, and you need to know about this as a clinical relevance. Even there is a normal X-ray, you need to still have a suspicion, high suspicion, if the injury mechanism, if the mechanism of injury suggests. Positive signs include widening of the mediastinum, widened left paraspinal space, tracheal deviation to the right, depression of left main bronchus, loss of aortic contour, loss of the aortopulmonary window, hemothorax, rib, and vertebral fractures. So if in your exam scenario it's mentioned any of these positive signs in X-ray, you need to have high suspicions of beta. The signs again are widened mediastinum, widened left paraspinal space. Well, of course, the aorta is on the left side. Tracheal deviation to the opposite, that is deviation to the right side. Depression of the left main bronchus, because again the hematoma will be on the left side, so left bronchus will be depressed. Loss of aortic contour, loss of the aortopulmonary window, hemothorax, rib and vertebral fractures. So this should give you a high suspicion of beta in the exam scenario. In CT angiogram is a gold standard. Registry data showed CTA rose the diagnosis from 34% to 93%. CTA performance, the sensitivity is 97 to 100%, and negative predictive value is 100%. Specificity is 83 to 99%. That perfect NPV makes it the definitive screening tool. That means the negative predictive value is 100%. What about the IVUS? IVUS used when CT angio is equivocal and has the highest sensitivity than angiography in that setting. Aortography is now intraprocedural only. Now the very important topic is the management, and again this you need to do depending on the grades. There are three physiological states. State 1, patient will be dead, no further intervention. That's you can understand because, as we said, 90% patient will not arrive to the hospital alive. State 2, hemodynamically unstable, active hemorrhage from any source. Resuscitation and hemorrhage control take priority. The hemorrhage control and resuscitation will take the priority. State 3, hemodynamically stable patient, continued injury, blood pressure control, definitive CT or IVUS, plan open or endovascular repair, institute surveillance. Now, transient responder, patients with contained aortic tear often respond transiently to fluids, then deteriorate suddenly. Early recognition prevents cyclical resuscitation that precipitates free rupture. Permissive hypotension is very important until the injury is characterized. Blood pressure control in stable patients by beta blockers, IV vasodilators, target systolic pressure below 120 mm for grade 1 lesions, monitor in level 2 and level 3 with invasive arterial pressure and CVP. The head injury dilemma, this is another very important topic to be clear about. Head injury demands raised map for cerebral perfusion, whereas beta demands reduced aortic wall stress. These directly conflict each other, so what would you do? Severe head injuries may require invasive cerebral pressure monitoring. Head injuries also contraindicate systemic heparinization, which is required for open repair. So know this tension and present both sides. If you clearly can justify which you're doing for what reason by knowing this logic behind, then that should be acceptable in the exam. Now let's talk about the definitive management, which is grade-based protocol. Grade 1 is IVUS assessment, beta blockade to keep the systolic blood pressure below 120, and the CT follow-up according to regional or local protocol. Grade 2 and Grade 3 are for elective or scheduled repair after stabilization. Grade 4, immediate repair on arrival or diagnosis. Conservative management, the mortality is 46%, open repair, the mortality is 19%, and endovascular repair, the mortality is 9%. So you can see that the endovascular should be the preferable repair modality. Beta should preferentially be managed endovascularly, and that is the recommendation in most of the guidelines. What about open surgical repair? And this is indicated for hemodynamically unstable patients, large volume hemorrhage from chest drains, contrast extravasation, rapidly expanding mediastinal hematoma, or penetrating injury. Approach is usually left thoracotomy, single lung ventilation, aortic cross clamping. Clamp and sew technique outcomes: death 10 to 20%, stroke 4 to 6%, paraplegia 2 to 10%. These are the major complications. The bypass repair modality is another one, which involves cardiopulmonary bypass, left heart bypass, or fem bypass. This significantly reduces paraplegia risk by maintaining distal aortic perfusion. The registry data shows open repair fell from 100% to 35% of cases between 1997 and 2007, which you can obviously see the more inclination to the endovascular repair. Delayed repair of 24 to 48 hours is applied in stable grade 2 and grade 3 after resuscitation and managing the other injuries. What about the endovascular repair? Endovascular repair of beta rose from 0% to 64% in 2007. It is now the first-line management option, not a fallback for high-risk patients, but the default for all suitable anatomy. No thoracotomy, no cross-clamp, no single lung ventilation, no cardiac bypass. These are the major advantages of endovascular repair, and that's why this is the gold standard nowadays. There are some technical challenges that you need to know for your exam. The access in younger patients have narrower, less atherosclerotic iliac arteries. Passing 16 to 24 French sheath is challenging. Lower profile devices and flexible hydrophilic sheaths help. Iliac conduit are an option. Arch angulation is another challenge. Younger patients have greater isthmus and angulation. A straight stent in a carved aorta creates sideward systolic impact, risking graft collapse or thrombosis. Landing zones, again, at least 20 mm is required. This often necessitates coverage of the left subclavian artery. And again, device sizing is another challenge. Device designed for older aneurysmal aortas may be significantly oversized in young patients, risking vessel damage or stent collapse. Wink sock effect, another important thing to know. Arch hemodynamics can push the graft distally during deployment, and this is controlled by hypotension, as this counteracts this effect. Pediatric use is another challenge. Long-term risk of endoleak and stent migration with aortic wall growth, and this must be considered in this age group. Surveillance, very important. Cumulative radiation in young patients is a concern, so MR aortography should be considered as an alternative. Now let's talk about the complications and outcomes. In endovascular repair, graft-related complications up to 20%, including endoleak up to 14%, half treated endovascularly, only 4.8% require conversion to open. Type 2 embolic from patient left subclavian artery backflow in 1.2%. Other complications are access vessel injury, cardiac or aortic perforation, stent fracture, migration, collapse, or kinking. Left subclavian artery coverage, often necessary for adequate proximal landing zone. Arm ischemia risk is relatively low. However, left subclavian artery coverage carries a 2.6% stroke rate and 1.6% paraplegia or paraparesis rate. So just for exam, remember these numbers: 2.6% stroke rate and 1.6% paraplegia rate by covering the left subclavian artery. The cerebral vasculature must be assessed before stenting. Carotid and vertebral patency, circle of Willis collaterals flow should be assessed. Now let's talk about the revascularization options if you have to cover the subclavian artery. The transposition of the left subclavian onto the left carotid is the preferred surgical option. The carotid subclavian bypass can also be done. Chimney stent alongside the main body device, technically possible, and also there is nowadays branch TEVR are there, and scallop can also be introduced nowadays. Now, outcome comparison versus endovascular versus open. The procedure related mortality in endovascular is 2%, open is 14%. 30-day mortality 8% versus 20%, stroke 0.8% versus 5% in open. Paraplegia is 0 to 1% in endo, and open is 5.6 to 7%. So everything is higher in open. Overall B-type mortality fell from 22% to 13% by introducing the endovascular repair. And this attributed to the better imaging, structured blood pressure control, and the shift to endovascular repair, as we mentioned. However, the endovascular repair carries a higher reintervention rate than the open repair, and patient selection and lifelong surveillance are very important in this matter. And high volume centers have lower complication rates and shorter hospital stays, and supporting centralization to dedicated tertiary trauma center with hybrid theater opportunity and multidisciplinary team involvements. There are some important points to remember. The beta blockers important in intimal tear under 10 mm for conservative management, and CT should be done according to local or regional protocol as a follow-up CT scan. Large flaps over 10 mm, we need to re-image sooner, usually at 7 days. And if the ACAB is present, endovascular repair within 7 days if other injury allows. And CT follow-up should be done at 1 month, 6 months, and 12 months. And again, this depends on regional protocol. If arch hematoma is over 15 mm with hypotension, this warrants urgent endovascular repair. B-type with head injury requires raised blood pressure, treat urgently, as because this will warrant catastrophic hemorrhage by raising the blood pressure, so you have to repair this urgently. However, the blood pressure needs to be raised to manage the brain injury, which is the priority. Now, endovascular repair is preferred, we said about it, and urgent repair is done within 24 hours unless life-threatening competing injuries exist. Endovascular repair for rupture, pseudoaneurysm, and intramural hematoma Intimal tears, conservative surveillance, open repair only if young fit patient unsuitable for endovascular repair. Left subclavian artery revascularization on individual basis depending on vertebral collateral supply. Spinal drainage only required for neurological symptoms, not prophylactic. The general anesthesia is preferred. Now, we already spoke about some important numbers. Just to recap again, the conservative management of beta gives the 46% mortality. Endovascular has 9% and open has 19% mortality. The complications will vary from, as we said, 9 to 20%, that is 10 to 20%. We can say in roughly stroke 4 to 6%, paraplegia 2 to 10%, and in endovascular 30-day mortality is 8 versus 20, stroke 0.8 versus 5.3, paraplegia 0 to 1 versus 5.6 to 7. The drawback is reintervention, long-term imaging follow-up that we already know. And this graft complication can happen in 20% and endoleak up to 14%. Left subclavian artery coverage, the risk of stroke 2.6%, paraplegia is 1.6%. Landing zone more equals to 20 mm is very important. Urgent repair in less than 24 hours after stabilization of other injuries, and spinal drainage symptomatic patient only, not prophylactic. Left subclavian artery, so spinal drainage symptomatic patients only, not prophylactic. Thank you very much. We are at the end of this episode. Thanks for listening to Proximal Control Vascular Surgery Exam Prep. If you have found this useful, stay tuned, because in the next episode we will discuss more on vascular trauma. We will talk about upper limb and neck trauma as well as lower limb trauma. Very important topic for the written as well as the clinical and oral exam. As always, with your support, we will grow together. Keep listening to Proximal Control, because in vascular surgery, control is everything.